Okay, President Kirkbride, we are all set.
Thank you, Staff Member Melvin. We're going to begin after lunch here with a presentation regarding the Oregon Wellness Program. This is mailing C, starting with Executive Director Runyon.
Executive Director Runyon, good afternoon. I hope everyone had a nice, fruitful lunch, or I'll leave the dad joke out of that. And thanks for coming to this very special presentation, and I'm excited to have our guests here today. And before I turn it over to them, I'd like to take just a moment to share a piece of my own story to create a transition when we take over. In the fall of 2023, before coming to the board, I was the PIC for a Rite Aid in Milwaukee. And I can still vividly recall the physical weight I carried on my shoulders during that time. There were countless 14-hour days where I would go in early to clear the queues, work through lunch to check in C2s, and stay late to clean it all up and prepare for the next day. I did all of this while administering vaccines every 15 minutes, verifying prescriptions, counseling patients, and supporting my technicians in the fleeting gaps in between. There were nights I was so utterly exhausted by the time I got home that I simply couldn't sleep. I would lie on the couch to avoid waking my partner, who was already in bed, just blankly staring at the ceiling, wondering how I was going to do it all again the next day. It was a paradox. I was doing entirely too much, yet at the same time felt like that was never enough. Day in, day out, week in, week out, that was my reality on repeat. And let me be clear, I'm not special, and this story is far from unique. Every single day across Oregon, pharmacists and healthcare workers in general endure this exact plight. We answer the call regardless of the cost, giving of ourselves long after the well has run dry. Sure, we can sustain this pace for a while, but that kind of burden always demands a toll, and we rarely get to choose when or how it comes to collect. This is where I believe we're light years behind where we should be. We live in an incredibly advanced era of self-driving cars, generative AI, and immediate access to the world's knowledge. Yet comparatively, our societal understanding of mental health, wellness, mental illness, and the shrinking space in between remains severely limited. That is where my role as executive director comes into focus. I want to demonstrate that my priorities extend far beyond presentations, policies, and rules, and that I care deeply about the mental health and well-being of our licensees. And that is exactly where these amazing individuals from the Foundation for Medical Excellence and the Oregon Wellness Plan step in. They offer vital services at critical times, ensuring that you have access to that same potentially life-saving care and grace in times of crisis that you extend to your patients every single day. And with that, I will turn it over to Eden Banter and Dr. Ellen Singer.
Thank you so much for that story and sharing, and for inviting us to participate and meet with all of you.
Gary, could you pull the microphone close to you? It needs to light up red when you speak. Thank you.
How's that? How's that?
Better. Thank you.
Yeah, thank you for inviting us to speak. Dr. Singer, do you want to say anything?
Thank you very much. The Oregon Wellness Program is independent of the Foundation for Medical Excellence, but the Foundation for Medical Excellence is the fiduciary for the program. And so my role is more of an advisor, and I'm not clinically active in the program, but can answer to the clinical concerns.
Okay, next slide, please. So I'll just start right off the bat with what we've been discussing with Director Runyon about a collaboration between the OWP and the Board of Pharmacy. So the Oregon Wellness Program requests that the Oregon Board of Pharmacy commit to OWP funding to cover pharmacists, interns, certified Oregon pharmacy technicians, and pharmacy technicians who are licensed and live in Oregon. Director Runyon is currently working through the procurement process with the Department of Administrative Services. The contribution for 2026 to 2028 that's been proposed would be $76,500 annually. This contribution would cover counseling for at least 125 Board of Pharmacy licensees and provide up to 375 mental health counseling sessions per year. Next slide, please. A bit about us, the Oregon Wellness Program. Our mission is promoting wellness for healthcare professionals in Oregon through coordinated counseling services, education, and research. Currently, we cover over 142,000 licensees, including nurse practitioners, registered nurses, certified nurse assistants, licensed nurse practitioners, physicians, PAs, podiatrists, acupuncturists, dentists, dental hygienists, and dental therapists. Next slide, please. If the Board of Pharmacy were to join our mission, we would be able to cover over 156,900 licensees, and including the groups we mentioned earlier. Slide, please. So the OWP vision, it was created by and for healthcare professionals. So it was very important to them to make sure that the program we were creating addressed any barriers that healthcare professionals specifically face. It's confidential and voluntary, which was critical to the vision. There's no reporting to insurance or employers. And it's voluntary, which means it's self-referral. So nobody's going to be sent to have therapy. They would choose it themselves independently. It's complimentary, which obviously means it's free, but the crux of that is that that contributes to the confidentiality because there's no insurance trail or paper trail, which is important to providers. It's timely and flexible, which if anybody has sought out mental health care in the last couple of months knows, you could call 8 people, you could hear back from 6 of them, 5 of them wouldn't be able to see you at all, and 1 of them could see you in a few months. So with our program, we have a group of 32 mental health providers, and they are committed to seeing a client in 72 hours if the need is urgent. But otherwise we'll see them, and they hold spots, we'll see them in a very timely fashion. It's flexible in that we cover the entire state. So we have providers from around this, or mental health providers from around the state. And in addition to being located around the state, all of our providers provide telehealth, which is, works well with working professionals. 2 of these things that helping address burnout epidemic and reducing barriers statewide, Dr. Singer will talk about a little more fully later in the presentation, and the funding follows the client, calls back to the confidentiality and the complementary that no money is exchanged between between the licensees who use our service and the provider. We pay the providers directly for the complimentary sessions. Yeah. Next slide, please. A quick overview of the program. The project is part of the Foundation for Medical Excellence, which acts as the administrative hub. We're guided by an executive committee committed to the program's success that meets monthly. We just met yesterday. It's a statewide effort providing self-referred, highly confidential, urgent mental health services to active clinical professionals. The things it isn't is it's not an emergency service, and it does not handle substance abuse disorders and does not handle clinical competence concerns, which are the purview of the professional licensing boards. Next slide, please. Program benefits. I just added this in because I wanted to emphasize how easy it is to use this program. All eligible licensees can receive up to 3 complimentary mental health counseling sessions by self-referral. You just go to the website, you get started, you get to see a full list of our mental health providers and their profiles. You find somebody that seems like a good fit, you reach out to them, you say, I want to use my OWP benefit, and you're good to go. So, it's very easy. Next slide, please. This is just an overview of our 2025 demographics of the different groups that were represented in our clients. You can see it's a lot of health systems, but there's some interesting groups in there too that might not otherwise have access to the program, which is what's so great about covering all the licensees and not just certain healthcare organizations, like the school district employees, health professional employees, and there was somebody from the corrections department, which was interesting to me. Private practice employees, obviously. Next slide, please. This is an interesting slide because it shows the growth of the OWP since 2017. In 2017, it was a pilot program and formalized in 2018. And from there, you can see a steady progression in the utilization by sessions. In mid 2022, it got really interesting because we added in the nurse population. And from there, we just really took off. At the end of 2023, we realized, we're looking at utilization trends, and we saw that if we kept going the way we were going to hit 5,000 sessions in 2024. And this was just financially not sustainable for us. At that point, we were offering 8 complimentary sessions, and they were renewable year to year. So we had a lot of repeat users, which is great, but we realized we needed to do something to keep the program viable. So in mid 2024, we reduced our benefit offerings to 3 sessions and a one-time only benefit. And that has helped us out immensely. We're still able to serve more clients as a result. And you can see though that the number of sessions went down dramatically as a result of that benefit change. And then another thing I wanted to point out, the important to know is that our new client rate has remained consistent, even though it looks sort of like we took a huge dive in our utilization. We're actually serving as many people. We're just offering fewer sessions and one-time only benefit. Next slide, please. This is just a quick shot of who's using the program right currently, or in 2025. It was pretty evenly split between the medical board, board of nursing, and the board of dentistry had a little less than 2% participation. Next slide, please. This is just an overview of 2025 utilization. We had 182 clients, 431 sessions. Next slide, please. These are some testimonials from our providers. I'll let you read them on your own. Laura said they have felt seen with their importance and their needs with the support of the OWP. Many have reported a return to greater contentment of work and in their professional lives after accessing the benefits, which is a pattern we've seen time and time again in testimonials from both the mental health providers and the clients themselves. Next slide, please. And this is a client testimonial. I would encourage everybody to take the time to read fully. I'm sure you'll find your experiences reflected in them. Being an emotional chameleon during a 12-hour shift, I felt like that encapsulates a lot of what it is to be a healthcare worker these days. So I guess the underscore, I have gained coping skills. I have improved my communication skills with patients and coworkers, and I'm more self-love. So that's sort of a glowing review for what we can do with this program. Next slide, please. Okay, I'll turn it over to Dr. Singer to talk about our research.
So it's really, I want to underscore 2 things with some of the benefit changes. The benefit changes were not taken lightly. There was a lot of debate, but our mission and goal was to make sure that when we had clients who needed care, we could serve them. And so we wanted to make sure that we could keep the access open. And so that put the boundary on the benefit and also the boundary on the recurrent use so that we could have more people having a touch of the service with a choice to then move on. They can stay with the same therapist. They just have to figure out either private pay or to use insurance with the therapist. And most of the therapists take all the commercial insurances. So it's not that big of a deal for people to do that. And so and the therapists have been very committed to keeping people in session longer. So our steering committee is very thoughtful about trying to increase the benefit amount as well. But again, we wanted to be conscientious of keeping the program afloat and available. So research, Dr. Gerard, our founding, sadly now deceased medical director, commissioned this research study with colleagues at OHSU to look at kind of what were the outcomes and some of the described benefits of the program. Next slide. So this was a cohort study, kind of looking at folks who are both users and non-users and asking questions around quality of life scores, kind of checking for adverse childhood experiences, which is kind of one of the ubiquitous ways to say somebody at higher risk, they've had more trauma in life, and what barriers do they perceive to mental health access. Next slide. And basically, in total, the OWP users were averaging about 8 visits per session, and many program users at the time had been using this for 26 months. And I think that this study design, which was all done based on confidential data, was done before we made the benefit change. But there were in this cohort study, again, there was a large distribution of people who had used the program. Go ahead. So one of the things that we did find, and I don't think that this is unusual to healthcare, but I think it's unspoken in healthcare, is that up to almost 40% had described significant adverse childhood events, which can include, family separation, loss of job, moving and transition, drug or substance abuse, death of a parent, all sorts of things that put people at risk for both physical and emotional illness as they age. That's based on Feliti's study with the Kaiser population. But we know that as the higher your ACE score goes up, the more likely you are to have problems. Healthcare, I think, sometimes draws people in who want to heal themselves by healing others. And I think the OWP clients express that. Also, I think our therapists are very aware of that and can work with people who have that kind of mindset. And so there's a lot, the higher those are, the more likely people are sometimes willing to seek care, but sometimes in healthcare, avoidant of care. Next slide. So what we found is with the folks in this program compared to the cohort who didn't have the benefit of this program, again, the benefit of this program is a posse of therapists who are very savvy about the care of professionals who work in the medical field specifically, that the longer people are, there's more a sense of that I have self-compassion and compassion for others. There was definitely a decrease in burnout scores over time for folks who participated in the program. And there was definitely a decrease in that risk of secondary stress. So think about somebody who's had a high experience of life events who comes into healthcare to heal themselves, and then is like the nurse who was describing her episodes in the emergency room is having to pivot and change their emotional reaction. There's secondary trauma with that, and so that this program helps heal that secondary trauma. And so the barriers, this I think is the most important thing, and I think this speaks to Mr. Runyon's concerns about why this program is so important for your group specifically, is cost and access and privacy are really the critical factors to getting in. And cost, I don't think is it's not the cost of the actual services, it's the cost of figuring out how to get the services and the time cost it takes to get it. So that one-click, one-stop shop and easy access is really a time saver for folks. And when people in healthcare tend to reach out, they need it much more quickly because they don't see themselves as being at risk until they're deep into it. Next slide. Okay, do you want to take this one?
Sure. Next slide, thanks. So I don't want to go into this too deep, but I just wanted everybody to have a familiarity of the OWP and where we get our funding. So the State Board of Nursing contributes $250,000. The State Board of Medicine contributes $125,000 annually, and the Board of Dentistry $40,000. Important things to note about this is that, and then we have the rollover support. So when we were facing that bit angry red column on our budget, we got some gap funding, one-time only gap funding from Care Oregon and EOCCO. So we've been working that down since, and so that's contributed to our funding. each of the boards that give funding, it's important to know that it is restricted to the licensees of that board, the spending. So we won't be dipping into the, into the physicians' funds for for pharmacy or vice versa. It stays and it only serves that population. Next slide, please. And this is, again, I'm not going to go into this too much. The points I wanted to make about the funding is that the funding is restricted to the licensees who provided the funds. What else did I want to say about this? That occasionally, like here you can see with the nurses, we had a grant from Pacific Source. We occasionally have other funds that we are able to also contribute to the care of the licensees, but and we more so in the beginning, but less so now. We had healthcare system support that they would write checks occasionally, but everybody's under obviously a lot of financial constraints in the last few years. So that's been less too. The administrative and marketing services are covered by the board of nursing and the medical board. So that's they cover the cost of my time. And then you can see that $11,000 research that was contributed towards the research about the OWP that Dr. Singer just presented.
That was a one.
Yes,
That's not.
exactly. Sorry, let me think if there's anything else I want to say about that. I think that's it. I don't want to get too much into this. I think if you go to the next slide, you can just see the similar budgets for the OMB and the OBD. But yeah, and that's sort of where I think I wanted to end, and we're open up for questions from anyone.
Staff member Melvin, President Kirkbride, would you mind facilitating that?
Yeah,
Thank you.
absolutely. So we'll go through each board member. Thank you for your presentation today. That was very informative and helpful to see kind of how the other entities have both resourced it and utilized the service. So that's kind of puts it in perspective. I will pass it over to Vice President Kroger.
Board Member Kroger, thank you very much. I don't have any questions at this time.
Board Member Joyce, thank you for the presentation. Mental health awareness, there's definitely, the awareness portion has definitely increased amongst us healthcare workers. And for us, it kind of boils down to patient safety. Where if we're not there mentally, it affects patient safety. So I'm thankful for this program. Also, I just, out of curiosity, most of the clients that are seen, I'm assuming it's all pretty much work related. It's not like somebody going through a divorce and wants to, it could be anything, right? I mean, because it could all affect patient safety.
Yeah, I think if you're, just because you have a degree, you're not immune from any of the things that affect human beings. So, and so there are two things I think about this program. This is a licensed mental health program, and therapy is all about I'm here, and it combines what got me here.
Right.
And also where am I going to go forward. This program does not include coaching, where we've had debates about that. Coaching is kind of an unregulated industry, and it's kind of booming in the healthcare space right now around ways to kind of do better, whether that's an off-ramp to licensed practice versus, really trying to guide things. And full disclosure, I'm a certified coach, and I coach within the legacy system now across the enterprise. So I can see it from both, from both places. But right now, what we are really focusing on is I'm in mental health crisis. And the key thing here is, I think, regardless of, the stories that you hear, Mr. Runyon's, whatever the stories are, by the time somebody who's realizes that they're in a hard place in the medical community, they've often tried to mask, camouflage, self-manage, self-medicate, whatever it is. And so our therapists are very savvy about helping people in that space, and then also recognizing that maybe there is a substance use disorder or other things, and helping them get to the right services, or that there's an underlying mental health concern that needs medication and, mood disorder or something like that, and we can get access to psychiatry as well. So this is really to stabilize immediately and then try to help people move forward, but in a very rapid access way when they hit that moment.
Absolutely. I mean, it's a much needed, service. And there's so much pressure with, healthcare workers, coming in the pharmacy, we are stressed out by, insurance companies, cutbacks from our employers, and not just pharmacy, healthcare workers are being contracted, ER doctors are being contracted, nurses. There's always a threat of strikes and so forth, and there's always like a workload conflict. For example, you'll have hospitalists going on strike because they are taking care of too many patients, and so there's stress coming from all directions in healthcare. So I'm glad that this is here. It's unfortunate it's only 3 sessions, but that's, as you showed us here, as for certain reasons. But no, thank you very much for the presentation. I'm glad it's here in Oregon for us.
Member Smith, thank you for your presentation and no further comments at this time. Thank you.
Board Member Maslow. Yeah, just wanted to thank you for doing this. It's, I think, underappreciated how little mental health training, speaking as a pharmacy student, you get. We had a course in our curriculum that was for mental health first aid training for pharmacy students, just to kind of get them into the workforce, doing that, knowing how to manage it. But again, it's just, there's so much to do. So I'm glad you guys are providing this service.
Board Member Chen, thank you. What was the plan for onboarding the Board of Pharmacy and the dollars where were the dollars going to come from so that we could play with the nursing board and the medical board and the dental board?
Executive Director Runyon. So I think if we zoom out and take a look at the cumulative effect of our sustained commitment to financial stewardship at the board in the context with the vacancy savings alone that we've amassed from me taking on the roles of CFAO, Strategic Initiatives Manager, Pharmacist Consultant over the last year plus. Even though that's a different allocation and we couldn't, without authorization, take it from there to pay for this, for example, it does play into the overall picture of our financial health or stability, such that this nominal fee for the year's services will not tip the scale discernibly in one way or another. So we already had the funding present in the particular allocation that this would come from. Number one, so no fee increases would be necessary. But number two, in addition to that, because we've been so judicious with using our resources and with those vacancy savings incorporated into that, that creates the overall picture where this is negligible. It's a negligible expenditure. So if that answers the question, that's where the money is going to come from.
This is Board Member Chen, and I truly appreciate just was said. However, my mom hat says doing all of those things to be fiscally responsible could possibly lead to you being one of the first people leaving the program.
Executive Director, I'll lead by example if that's what it takes to get people in here. I'll do it.
So I would like to see us have a sustainable way of funding this for our licensees without sacrificing a single person making this a viable thing for us at this time is what my goal would be. And how that would look. And I'm not sure how the other boards are funding this program for their licensees, like the $250,000 from the Board of Nursing, the $125,000 from the Board of Medicine.
I don't really have insight into their budgetary
Okay.
process for that, sorry.
I do believe there is some things where I think my understanding with the Board of Medicine is they can add a small tag to the license fees for each provider to cover this global service for their licensees. It's, each board is a little bit different.
And we do, I think we all do that for the HPSP program, right? That's okay.
This is separate from that.
I understand. And Diane Solomon is a good friend. I'm so glad to see her name, and she is one of the best mental health people. You only had a little tiny comment on your slides. When you're listing the people that you're serving, you had the
Closer to your mic, Kat.
you had the advanced practice nurses, and then you had this licensed nurse practitioner. I think I'm wondering if you meant to put the LPN, the licensed practical nurse. Because that was a kind of a duplicate, so. Anyway, other than that, beautiful presentation, excellent program. I would love to see our licensees have access to it too. With the caveats that I already mentioned. Thank you.
Hall, thank you for the presentation and seems like a really great program. I too was concerned about, annual funding. If, the Board of Pharmacy were to take that on as well at our licensees. I was, a little, I guess, saddened to see that substance use disorders wasn't, handled, and I'm assuming it's because it's requires more specialization, or I don't know if you guys could speak more to that.
I think it's an and both in that situation. So substance use disorders are difficult in licensing, and you know, with the Lorna Breen Foundation changes that at least the Board of Medicine has made and many boards have made, the issue of, and many, I think like Legacy, for example, as a credentialing hospital, is not asking questions about mental health illness, but you do have to kind of go through that in the relicensure with substance use disorder. So substance use disorder usually requires more specialization of therapy services, you know, so people who have specialization in counseling folks with substance use disorders, as well as usually a medical component. And so that is, and because of the other health professionals kind of programs, you know, substance use disorders was out of scope when this program was founded. I was not the medical director of the Foundation for Medical Excellence when this program was founded. I took over just as they were kind of growing and changing. So I can't speak to the conversations that were had around that, but I think where we are is where we should be in this space right now because of that complexity around that. But I think it's a good point and it's a good call out because it's a major issue in healthcare.
But thank you for the presentation.
Can I make one other comment for your board's information? So the Foundation for Medical Excellence is a nonprofit educational think tank organization with an emphasis on, you know, helping with conversation around health policy, but also healthy practices, career sustainability, safe prescribing, safe interprofessional communication. And so our organization does a safe prescribing course with the College of Physicians and Surgeons of British Columbia in a shared way. We have the bandwidth and I have the experience to help. So if the Board of Pharmacy wanted to per se, we would like to support educational efforts to just educate our practitioners around some of these issues or around some of the how to identify self-stress and things like that and be of a more educational and not therapeutic thing. We're also an organization that you can contact through Eden. It would be me and Eden kind of helping pull that together, but that's something that we can commission for you if that's of interest.
Remember Kirkbride, I do have one more question as everyone's cycled through. The funding is set up as annually, but it looks like the utilization in some of the cases isn't matching maybe what that annual funding is. So does the money roll over and like build up in a fund so that it just continues to build and be there?
Yes, exactly.
Okay. Thank you. Our chair. I forgot. Been a long 2 days. Thank you, board members, for your discussion. Do we need to do anything else today, Executive Director Runyon, or is this our next steps?
Executive Director Runyon. To wrap this part up, we don't need to do anything else. I've been working on the last several months on the other pieces that are required. I think we got the single source procurement requisition posted. It has to stay up for a minimum of or 7 days, I believe. And it's all public information. But we got that posted, and then probably about 5 days left on that. And that'll take care of the procurement piece. But other than that, there isn't anything else that I need board action for that we need to cover here today.
Okay, thank you. And thank you to our guests for joining us.
Thank you.
Thank you.
Right, next up, we will continue with a presentation related to Drug Supply Chain Security Act, DSCSA. This is mailing B3 with staff member Ephraim.
You, staff member Ephraim, I'll wait 1 moment while staff member Melvin pulls everything up. Let me know when you're ready. We are ready to go. Good. Yep. All right. Good afternoon. We're now going to transition to discuss Drug Supply Chain Security Act and the applicable rules that will need to be amended. As always, sorry, next slide. As always, we start every policy discussion with our mission to help guide us through our conversations. The board is tasked with ensuring high standards and practice through effective regulation to ensure patient safety, health, and welfare of Oregonians. Next slide. The Drug Quality and Security Act, known as DQSA, includes both Title I Compounding and Title II Drug Supply Chain Security Act, known as DSCSA. The DQSA passed in 2013 and was created in response to the 2012 fungal meningitis outbreak caused by contaminated steroid injections compounded by the New England Compounding Center, which killed 64 people and harmed over 750 patients nationwide. The federal law expanded the FDA's authority to oversee compounding pharmacies and track prescription drugs throughout the national drug chain supply. Today, we're going to focus on DSCSA, but please remember we will also be addressing outsourcing facilities and our bigger rules overhaul. Yes, it is part of DQSA, but is part of Title I, drug compounding, and not Title II, drug supply chain security. Our current regulations place outsourcing facilities in manufacturer registration location. As we make updates to our rules, we will need to remove outsourcing facilities from the manufacturer location and create a new division for outsourcing facilities as they have different requirements than manufacturers. The DSCSA was put in place to protect consumers from counterfeit, stolen, contaminated, or harmful prescription drugs by building an interoperable electronic track and trace system across the pharmaceutical drug supply chain. These goals are to be obtained through 2 main processes. First is through product tracing, which includes outlined steps to achieve an interoperable and electronic way to identify and trace certain prescription drugs at a package level as they move through the supply chain. By 2015, it was through lot level, and by 2023, it was through package level. Package level verification in action required 2D barcode scanning. Every unit received must be scanned to compare the physical product data with the electronic transition data. Real-time interoperability. System communications need to be seamlessly utilized using the Electronic Product Code Information Service Standards, known as EPSIS. Quarantine and verification. Any serial mismatch immediately triggers holding to prevent illicit entry. Quarantine and investigation requires steps for detection and response. Notification and record keeping. Product identification was required starting of 2017. Package level serialization. Every prescription drug must have the 2D data matrix barcode containing a unique serial number, national drug code, lot number, and expiration date, and electronic data exchange, which includes trading partners, having electronically transmitting transaction data. And secondarily, they plan to achieve these requirements through licensure. So wholesale distributors and third-party logistics providers are required to be licensed by the FDA or by the state. The DSCSA creates standards for licensure, and the FDA has a website to check licensure of wholesale drug distributors and third-party logistic providers. The website includes the required information from licensees' annual reports and links to each U.S. state board of pharmacy. It's important to remember there's a uniform national policy enacted as part of these laws. It prohibits any state or local government from establishing or continuing any standards, requirements, or regulations with respect to the licensing of a wholesale prescription drug distributor or third-party logistics provider that are inconsistent with, less stringent, directly related to, or covered by the standards and requirements applicable under this law, and that no state shall regulate 3PLs as a wholesale distributor. We will need to ensure we work closely with our AAG to ensure that we are in compliance with this when writing rules. One other very important thing to keep in mind, this law has been codified in 21 USC Chapter 9, Subchapter 5, Part H, and this is part of the FD&C Act, or known as the FDCA. As you may remember at our last board meeting, we shared a Ninth Circuit Court ruling that clearly stated that only the FDA can enforce the FDCA, and that if we need to be compliant with federal regulations to impose these requirements, or if the board believes it is in the best interest of the patient's safety to align with these requirements, we will need to articulate these requirements in our rules clearly. We will be keeping this in mind as we bring proposed rules to the board in the future. So our goal for today, we really are doing this to hopefully help everyone familiarize themselves with DSCSA. You have been provided the codified law at the end of this presentation and also in your resource folder to review at your leisure. Next, we need to obtain a good understanding of how DSCSA will impact the board's role in licensing and regulating of wholesalers and third-party logistic providers. And we need to create a plan to comply with these requirements through drafting of rules that are in compliance with DSCSA requirements. This will also require that we make necessary statute updates to the definition of wholesaler and to likely include third-party logistic providers. We'll discuss all of this in more detail over the next upcoming year or so. Next slide. So as you can see here, this is just an outline of what sections are listed in 21 USC related to these requirements. There is currently a notice to propose rules, which would then be included in the CFRs. And there is a section for rules sectioned off in the CFRs, but nothing has been added to date. So we will keep an eye on that. Next slide. This slide just represents a high-level visualization of the implementation process. You can see back in 2013, when this was signed into law, the DSCSA was given a 10-year implementation timeline. Different milestone dates were set with the requirements to help stakeholders prepare in a phased approach. 2015 to 2020 focused on tracing and licensing, lot-level product tracing, and the trading partner verification. And in November of 2023, the enhanced drug distribution security was effective, which required interoperable electronic tracing of products at a package level. This phased out the old transaction history and required item level serialization. And from November 2023 to November 2024, the FDA enacted a one-year stabilization policy. The FDA decided to exercise enforcement discretion to give trading partners time to comply with these requirements. Next slide. Following the end of the general stabilization period after 11/27/2024, the FDA instituted a phased exemption schedule based on the supply chain role. What that means right now, supply chain partners that are manufacturers, wholesale distributors, and large dispensers are now operating under full enforcement of package level electronic tracing. So as of May 2025, manufacturers and repackagers had full electronic serialization data transmission required downstream. August of 2025, wholesale distributor package level verification and electronic records exchange were required. November of 2025, large dispensers were required to have full interoperable electronic tracing receipt and storage. And November 2026, just around the corner, we will require small dispensers to become compliant unless they have a waiver, exemption, or exception issued. Small independent pharmacies, again, 25 or fewer, full-time employees have until 11/29/2026 to comply with the enhanced drug distribution security requirements. So they will have to ensure that they establish the interoperable data connection, that they choose and test the DSCSA data solutions, that they implement verification and product exception handling, they upgrade their record keeping retention for 6 years, and that they validate their authorized trading partners. Here we have listed the FDA guidance documents related to the DSCSA. I apologize, it is hard to see, but tried our best to have all of them on one slide. In general, the FDA's guidance documents do not establish legally enforceable responsibilities. Instead, the guidances describe the FDA's current thinking on a topic and should be viewed only as recommendations unless specific regulatory or statutory requirements are cited. These guidances were required to be created and are referenced in the USCs. There are over, at least currently, and counting, over 20 FDA guidances published on this topic. And as mentioned in a previous slide, to date, we do not have any CFRs or proposed rules, but they do have a placeholder. They announced in 2022 they were coming, so we'll see what happens. We'll keep our eyes out for that one. So just a little bit of terminology as we continue this discussion. It's helpful to have a super high level reference to some of the terminology that we discuss in future slides. So here we have listed what is the definition of product identifier, transaction information, transaction statement, and what is an authorized trading partner. We will focus in the next few slides on discussing more in depth the types of authorized trading partners and their requirements. So the first authorized trading partner we'll review is a manufacturer. It is important to remember that pre-DSCSA, manufacturers were required to be registered with the FDA and currently are also required to register with the FDA and our state Board of Pharmacy. The definition of manufacturer in DSCSA is a bit wordy, but for our purposes today, it is the person who manufactured the product. It's important to note that the definition of transaction contains a number of exemptions. For example, intercompany distribution of any product between members or an affiliate or within a manufacturer, the distribution of a product sample by a manufacturer, and we're going to address all of these in the future when we start proposing rules for the board's review. So per DSCSA, manufacturers are required to provide transaction information and transaction statements through an electronic product code information service. So they have to have real-time interoperability, and they need to have systems that communicate seamlessly using electronic product code information services. They're required to provide product identifiers known as serial item level traceability. So they're required to use the two-dimensional data matrix barcodes when affixed to or imprinted upon a package, and they shall be included in a linear or two-dimensional data matrix barcode when affixed to or imprinted upon a homogeneous case. A homogeneous case means a sealed case containing only product that has a single national drug code or NDC number belonging to a single lot. And this all must be verifiable. Verification requirements, they're required to identify and manage suspect and illegitimate products. So they're required to quarantine product until cleared, which requires prompt investigation in coordination with trading partners as applicable to determine whether the product is an illegitimate product, which shall include validating any applicable transaction history and transaction information in the possession of the manufacturer, and otherwise investigating to determine whether the product is an illegitimate product. If the manufacturer makes the determination that a suspect product is not an illegitimate product, the manufacturer shall promptly notify the FDA, as applicable, of such determination, and the product may be further distributed. If the product is deemed illegitimate, the manufacturer shall, in a manner consistent with the systems and processes of such manufacturer, quarantine the product within their possession or control and notify the FDA and immediate trading partners within 24 hours. Disposition the illegitimate product in their possession and take reasonable and appropriate steps to assist trading partners to disposition any illegitimate product that is not in their possession. They must retain a sample of the product for further physical examination of or laboratory analysis of the product by the manufacturer or the FDA upon request by the FDA. They're also required to respond to requests for verification. So upon receiving a request for verification from an authorized repackager, wholesale distributor, or dispenser that is in possession or control of the product a person believes to be manufactured by the manufacturer, they shall respond within 24 hours after receiving the request or other such reasonable time as determined by the FDA. If a manufacturer responding to a request for verification identifies a product identifier that does not correspond to that affixed or imprinted by the manufacturer, they shall treat the product as a suspect product and conduct an investigation. They are required to have a secure electronic database. So a manufacturer must develop and secure a secure electronic base or utilize a secure electronic database developed or operated by another entity. The owner of such database shall establish the requirements and processes to respond to requests and may provide for data access to other members of the pharmaceutical distribution supply chain as appropriate. The development and operation of such a database shall not relieve a manufacturer of the requirement to respond to the request for verification. For returned product, they have two different types, saleable and non-saleable. For returned product that a manufacturer intends to further distribute, the manufacturer shall verify the product identifier, including the standardized numerical identifier for each sealed homogeneous case of such product. If such product is not sealed, they have to verify the product identifier, including the standardized numerical identifier on each package. A manufacturer may return a non-saleable product to the manufacturer or repackager, to the wholesale distributor for whom such product was purchased, or to the person acting on behalf of such person, including a returns processor, without providing information described in the previous requirements. All records are required to be maintained for 6 years, and manufacturers must provide federal or state officials information within 1 business day, not to exceed 48 hours. Please note that the FDA also may approve any waiver, exception, or exemption to these requirements, and that those are reviewed on a biennial basis, either continued or expired. Next. The next authorized trading partner we will review are wholesale distributors. Wholesale distributors are defined in DSCSA as a person other than a manufacturer's co-licensed partner, a third-party logistic provider or repackager that engages in wholesale distribution. It's also important to note that the definition of transaction contains a number of exemptions that potentially apply here. Intercompany distribution, the distribution of a product among hospitals or other healthcare entities that are under a common control, distribution of certain drugs and medical convenience kits, IV fluid replenishment, dialysis drugs, and medical gases. Again, we'll get into these details in the future when we have to provide proposed rules. Also important to remember that the Uniform National Policy that we talked about in the beginning prohibits any state or local government from establishing or continuing any standards, requirements, or regulations with respect to licensing of wholesale prescription drug distributors that are inconsistent with, less stringent, directly related to, or covered by the standards and requirements applicable under this law, and that no state shall regulate 3PLs as a wholesale distributor. So for these requirements, we see very similar tenets as manufacturers. They also have to have a product tracing to the serial item level. So they are not allowed to accept ownership of a product unless it has the previous owner's information in that electronic format. And they also shall not provide to a subsequent purchaser without providing that information. Returns, again, they have two types related to saleable and non-saleable and have very similar requirements for those. A request for information is in alignment with what is required of a manufacturer. They must provide within 1 business day, not to exceed 48 hours. They also, wholesale distributors may engage in transactions involving a product only if the product has a product identifier, so they are required to have that also. For licensing requirements, there are a lot of specific licensing and inspection standards that are articulated in law regarding the following topics: storage and handling of prescription drugs, establishment and maintenance of records of the distribution of such drugs, the furnishing of a surety bond of $100,000 or equivalent, the establishment and implementation of qualifications for key personnel, the mandatory physical inspection of a facility to be used with wholesale distribution within the reasonable time frame from initial application of the facility and to be conducted by the licensing authority or by the state, and the prohibition of certain persons from receiving and maintaining licensure for wholesale distribution. So under prohibited persons, if a person has been convicted of a felony for conduct relating to wholesale distribution and any felony violation related to very specific sections of this law, also a person who would be prohibited from licensure if they have engaged in a pattern of violating the requirements of the section or the state requirements for licensure that presents a threat or a serious threat or adverse health consequences or death to humans, they may not be licensed. For inspections, the federal or state licensing authority may conduct the inspection or may accept an inspection by the state in which the facility is located or by a third-party accreditation or inspection service approved by the FDA or the state. They are required to only utilize authorized trading partners. Again, they must have a verification system in place to be able to identify suspect product, to quarantine suspect product, investigate and either clear or deem illegitimate product, and then to ensure that the product requires the notification to the trading partners and the FDA. They are required to use a secure electronic database, must keep records for 6 years, and respond to regulators in the same timely fashion. Slide. Dispensers. So dispensers mean a retail pharmacy, hospital pharmacy, or a group or chain of pharmacies under common ownership and control that do not act as a wholesale distributor, or any person authorized by law to dispense or administer prescription drugs, and the affiliated warehouses or distribution centers of such entities under common ownership and control that do not act as a wholesale distributor. So dispensers are required to ensure that there is product tracing at a serial item level traceability. So a dispenser shall not accept ownership of a product unless the previous owner had provided the electronic product code tracing information prior to or at the time of each transaction in which the dispenser transfers ownership of the product. But this does not include dispensing to a patient or returns or sales or to dispensing to another dispenser to fulfill a specific patient need. The dispenser is required to ensure that they provide the electronic product code tracing information. A distributor also may use agreements with third parties, including wholesalers, to meet these product tracing requirements, and the dispenser must maintain a copy of this agreement. Return product. They may return product to trading partners from which they obtain them without any of the product tracing information. The request for information from communication with regulators is slightly different. In the event of a recall or for the purposes of an investigation of a suspect product or illegitimate product, a dispenser shall no later than 2 business days respond to the FDA. For verification, it is a similar process to be able to ensure that they are quarantining, that they are investigating, that they're either clearing a product, deeming it illegitimate, and providing the appropriate notification to both the FDA and trading partners. And they are also required to have a secure electronic database, must maintain records for 6 years. And we already discussed communication with regulators. Next authorized trading partner is a repackager. A repackager is a person who owns or operates an establishment that repackages or relabels a product for further sale or distribution without a further transaction. They're already required to be licensed with the FDA prior to DSCSA, so similar to manufacturers. They are required to have product tracing. They may not accept ownership of a product unless they had received the electronic transaction information. And they also, at the time of transferring ownership of the product, must provide the owner with the required electronic transaction information. For returns, both non-sellable and sellable product, they do not have to have all product information to the originating trader partner pursuant to any terms and conditions with that entity that owns the product. If they received return product, they must verify a sellable return product before further distributing. They are required to have a product identifier, so they have to affix or imprint a product identifier to each package and homogeneous case of product intended to be introduced into transaction of commerce. They must only use authorized trading partners. For verification, they must identify and quarantine suspect product, investigate suspect product, and either clear or deem it illegitimate and provide the required notifications. Again, very similar to other trading partners. Request for verification. A repackager must respond within 24 hours after receiving a verification request or another reasonable time frame deemed by the FDA. Again, similar requirements from other trading partners related to electronic database, maintenance of records, and responding to the FDA within 48 hours or 1 business day. Next slide. Sorry, the monotony will end soon. We are so close. DSCSA is so exciting. I know, you're all on the edges of your seat. For third-party logistic providers, the final authorized trading partner is what we're going to talk about here. We sometimes refer to them as 3PLs commonly. The definition of a third-party logistics provider is an entity that provides or coordinates warehousing or other logistics services of production in interstate commerce on behalf of a manufacturer, wholesaler, or dispenser of a product. This is key, but they do not take ownership of the product nor have responsibility to direct the sale or disposition of the product. It's important to remember too, again, the Uniform National Policy. It prohibits any state or local government from establishing or continuing any standards, requirements, or regulations with respect to licensing of a third-party logistic provider that are inconsistent with, less stringent, directly related to, or covered by standards and requirements under this law. And that states may not regulate 3PLs as wholesalers. Luckily for us, this is not an issue at this time. We currently register third-party logistic providers as drug distribution agents. We will need to look into this further and possibly rethink this division in the future when we discuss proposed rules. So the requirements of 3PLs, they are required to be licensed by the FDA or by the state that they are located in. They have reporting requirements. On an annual basis, they must report to the FDA the state that they are located in and their registration number, and the name and address of the facility and all trade names under which they conduct business. They are required to comply with several regulations. They have to be licensed. They have to maintain access to warehouse space of suitable size to facilitate safe operations, including a suitable area to quarantine suspect product, maintain adequate security, have written policy and procedures to address receipt, security, storage, inventory, shipment, and distribution of product. They have to identify, record, and report confirmed losses or theft in the United States, correct errors and inaccuracies in inventory, provide support for manufacturer recalls, prepare for, protect against, and address any reasonably foreseeable crisis that affects security or the operation of the facility, such as strike, fire, or flood. Ensure that any expired product is segregated from other products and returned to the manufacturer, repackager, or destroyed. Maintain the capability to trace the receipt and outbound distribution of a product and supplies and records of inventory. Quarantine or destroy suspect product if directed to do so by the respective manufacturer, wholesale distributor, dispenser, or authorized government agency. Prohibit a facility from having a manager or designated rep that is convicted of any felony violation of the certain regulations that were cited before. Require mandatory background checks of a facility manager or designated representative of such manner. And upon request by such authority, a list must provide a list of all product manufacturers, wholesale distributors, and dispensers for whom the third-party logistics provider provides services, and their licensure is good for 3 years. Inspections. The third-party logistic providers are also required to undergo periodic inspections by the FDA or the state. All right, next slide. So with all of that, what does that mean to the board? We have a little bit of a background understanding of what the authorized trading partners are. And as you can see in our high priority category, many of them are listed there under the Drug Supply Chain Security Act. So we have manufacturers that list DDAs, but we're looking at third-party logistic providers, wholesalers, and outsourcing facilities. So these will be the 4 different divisions that we're going to focus on over the next year and a half, hopefully. Go to the next slide. And so for the next steps, as you can see here, I provided the board's 2024-29 strategic plan division vision to assist in our role updates. The highlighted sections, as we just discussed, manufacturer, wholesaler, drug distribution agent, and outsourcing facilities are the rules divisions we will be focusing on. Our tentative goal, pending other priorities that might require us to pivot, will be to complete these sections by 12 of 2027. One positive thing we have going for us is that all of DSCSA will be effective and fully implemented by the time we adopt any of our rules, and many other states have already adopted updated manufacturer, wholesale distribution, and dispenser regulations, so we have a lot of examples to pull inspiration and information from. And with that, I will open it up for any questions or discussion.
Thank you, Bree. Staff member Epperma. Your voice is so nice and soothing, but I will say we might have to do this in the morning next time, not after lunch.
I figured maybe the topic.
I do have a question though, as you were going through all of those, and just making sure I understand, because this is definitely not my area of expertise. The repackagers, is that in the outsourcing, or where do the repackagers fit in these that we see in our priority list?
Thank you. That is a great question. So typically we have put them under manufacturers because they are typically treated similarly. But we will definitely have to do a little bit more of a deep dive on them to make sure that we're doing that justice appropriately.
Okay. I think that was my only question. We'll go through because I think we all need to jazz it up a little bit. Board member Kroger, do you have any questions?
Board member Kroger, no discussion at this time. Thank you.
Board member Joyce?
Barbara Joyce, yeah, I absorbed everything you said. So. No, interoperable track and trace. That's what I caught. Yeah, so I memorized it. No, thank you for the presentation.
Board member Smith?
Board Member Smith. In thinking about this, would we have a requirement for when like medications get returned to stock? They're only good for a year. But if pharmacies are using this to track and trace the product from like the manufacturer to when it's dispensed, is that something that we could possibly look at changing at some point? I know inventory management is a big expense for pharmacies, and in theory, I feel like this could provide some extended shelf life for some of the medications that we return. Just an idea.
Staff member Frump, I took notes and I just want to make sure that I'm understanding clearly too. So are you referring to the 1-year expiration date from dispensing in general? So if it was returned to stock, that it still would have the initial date from when it was repackaged? Or are you talking about something else?
Yeah, return to stock. So let's say you package a medication for a patient, it gets returned to the shelf. Right now we have I think a year-long requirement for that. But in theory, if pharmacies were utilizing the DSCSA, I think you could track that. You keep track of that product, and in theory, it would last longer than that 1-year expiration date, and that just might be, might be beneficial to pharmacies on an inventory level.
Thank you. We can definitely pull that together. And I think the other consideration within that too is if it's in the original stock bottle or if it's been taken out, right, and how long potentially USP, but we can definitely pull all that together for future discussion. Thank you.
Thank you.
Member Maslow?
Member Maslow, thank you for that. No discussion on mine right now. I need that all to percolate.
Oh, and more coffee next time too, speaking of percolation. Board member Chin?
Jill, thank you for soothing, words, and I have no further comment.
Board member Hall?
Thank you. No additional comments.
All right, back to you. Or are we done with this topic?
We are done with this topic. So
Okay.
we hopefully will be bringing rules over the next year that the board will get to kind of digest this, but we just wanted a bigger overview so that you see how they kind of interplay, but we'll be bringing them probably singularly, but we'll try to have several moving simultaneously.
Perfect. Thank you. Up next, we have Executive Director Runyon to provide a board report, including financial and strategic plans update. Ready?
Executive Director Runyon, likely not be as soothing as for Bob. And perhaps a little more long-winded, but probably used to that now. All right, we'll just kind of smush all of this stuff together. So I'll give you a board and PFAC update, strategic plan update, financial update, etc. All in one fell swoop. So starting with the board and PFAC updates, I'm excited to share that in addition to all the work we've done and progress we've made over the last 2 months since we last saw each other, I've also been able to make some significant strides in filling vacant positions on both the board and PFAC. Just as a refresher for the non-Senate positions, the process operates on a rolling administrative timeline and generally takes about 6 to 8 weeks from the time of recommendation to final appointment. For Senate confirmed positions, such as the board members, the timeline's tied obviously to the legislative calendar. Therefore, the final opportunity for Senate confirmed positions in 2026 is coming up next month, September 8th through 10th during legislative days. Specifically, in terms of the PFAC updates, Governor Kotek appointed or reappointed the following people to the PFAC. Existing pharmacist member Courtney Sellers was reappointed through 4/30/2028. Existing physician member, Dr. Robin Virgin, was reappointed through 5/31/2028. New physician member, Dr. Stephanie Rika Larson, was appointed through 7/5/2028. And new pharmacist member, Joe Schnabel, was appointed through 7/5/2028. His name sounds familiar for some reason. I'm also incredibly excited to announce that through my partnership with OSBN, I've been able to recruit a candidate to fill our open APRN position. I submitted the recommendation to the governor's executive appointments team and received confirmation that they're on the list. And the appointment would likely be in September or October. So that'll round out all of the vacancies in the PFAC. And as far as the board updates go, as you're well aware, board member Maslow was confirmed and appointed to his current position on the board in June. Again, I'd like to thank him for joining us and look forward to his continued contributions. In June, I mentioned that I was exploring a few options to fill the vacant public member position on the board. After my best used car salesman pitch, I'm delighted to announce that I've recruited a candidate, recommended them to the governor's team, and as it currently stands, they would be confirmed during next month's legislative days. So we'll have a full board at that point. Next, we'll switch gears to the financial update. I'll have staff member Melvin pull that up. Bless you. And we'll scroll down to the June report. Okay, not really much to see here. Keeping with the trends that we've covered really over the last 6 months, our expenditures are significantly lower than expected. At 12 months into the biennium, and the expectation is to have roughly 50% of the allotted budget spent. However, total expenditures are currently 12.77% under that target. Again, this highlights the exceptionally lean spending and our continued commitment to our licensees and registrants to be good stewards of the resources we've been given. I just feel that if we ask a lot of others, we should ask the same of ourselves. Our cash reserves greatly exceed recommended targets. The standard goal for an agency such as us would be ending cash balance 3 to 6 months. Our projected end of biennium balance, it's about 8.64 months. So it's roughly about 50% above the top end of the recommended range. And I'll cover a little bit more about financial update and strategic plan update, which we will go to now. And we don't have a mailing for this, but this will just give you a high-level overview of the daily work staff has been engaged with since the board's last meeting in June, especially work that's related to the board's strategic plan. So in terms of key milestones, I have 4 updates for you, and I'll expound on each one after we go through the list. Number 1 would be the submission of the agency request budget. Number two is a revision and submission of the board's affirmative action plan. And number three, as you have heard from the presentation today, would be submitting the single source procurement requisition for contract with the Oregon Wellness Program. And lastly, would be submitting the application to the Lorna Breen Heroes Foundation to become a Wellbeing First champion. So I'll cover each of those four in depth. I'd like to take a moment to commend the collective efforts of my team here, especially staff members Hennigan, Graham, Melvin, and Shinoiki. We made several key changes to the budget narrative and are working on incorporating staff-specific duties into a standard work of sorts aimed at reducing the administrative burden for each successive biennium as it relates to the creation of the agency request budget. There will likely be some minor updates in the coming months. Otherwise, we'll await the next big milestone, which is the release of the GRB or Governor's Recommended Budget in December. I'd also like to mention what I would consider another big budget-related win here. And for the first time that any of our current employees can recall, or so I've been told, I preemptively shared the 10% reduction exercise with staff. That's a requirement historically kept quiet and I think avoided by management. And because transparency is a core value of mine, I wanted to clearly explain the why and how behind our strategy. I shared our plan to highlight that in a deliberate departure from past budgets, our proposed reductions would protect the front lines of compliance and licensing by absorbing cuts within the executive department and long vacant roles. So paired with minimal operational shifts, I built a 10% reduction plan that would guarantee zero impact on any current or full-time, any current full or part-time staff. It's incredibly important to demonstrate to the team that even if these cuts are enacted, which is unlikely, but in the event they are, the core of our agency will remain completely secure. Next, in terms of the affirmative action plan revisions, if I've read one strategic plan, I've read 100, and it's very common for these types of plans to get so lost in the clouds, if you will, or so lost in raising the ceiling that they can forget what actually happens on the ground. And I think, talk is cheap. And so what I really wanted to do was take a look at that and kind of bring it back down to earth and really focus on the things that we could do with our resources and staffing. I would rather do 3 things really well than have 100 things that we talk about, none of which we actually do. So once we get that draft approved, we'll distribute that to the board for your review. And furthermore, we use this opportunity working on the budget and the AA plan side by side to start a set of communicative building blocks, if you will, and that could form the basis of presentations and communications alike going forward. So essentially, we'd be spending less time saying the same things in different ways, and that would create a greater degree of unity or cohesion across both departments and within the agency, especially when we're out and giving presentations in the public and with outreach. And then we obviously have the single source procurement requisition for the Oregon Wellness Program. I really appreciate those individuals showing up here and the partnership that they've extended our way over the last couple months as I've been working with them behind the scenes. I'll keep you updated on the outcome of that requisition, and we'll probably hear word from that in the next 5 days or so. And again, we'll go back to the Lorna Breen Heroes Foundation and becoming a wellness first or well-being first champion. And that coalesces with the work, obviously, we did to initiate the potential partnership with the Oregon Wellness Program. So what is a well-being first champion, you might ask? So this program helps organizations audit and revise their credentialing and licensing applications to remove overtly and overly invasive mental health questions, supporting health workers' access to seek mental health care without fear of professional repercussions. So I'll just give Lorna Breen's story in about 4 bullet points. I think it's really important to hear, and so you have a better understanding of why this is important. Dr. Lorna Breen was a brilliant, vibrant emergency room physician and ER director at the Allen Hospital in Manhattan. Outside the hospital, she was a world traveler, an avid snowboarder, and a beloved aunt. In April of 2020, the pandemic transformed her calling into a nightmare. Within 3 weeks, Lorna treated COVID-19 patients, contracted the virus, and immediately returned to an overwhelming onslaught of sickness. She and her colleagues worked around the clock amid several shortages of PPE, oxygen, and beds. She kept going back into the devastation, even covering 2 separate emergency rooms simultaneously until she literally could no longer stand. By early April, completely paralyzed by exhaustion and having not slept in a week, Lorna was nearly catatonic. Yet her greatest fear wasn't the virus. She was terrified of losing her medical license or being ostracized if she sought help, believing it would be the end of her career that she had spent her life building. Tragically, Lorna died by suicide on April 26, 2020, despite having no prior history of mental illness. Only after her death did her family learn that licensing boards and hospital credentialing often require physicians to disclose mental health care, breeding a dangerous culture of silence and contributing to the 400 US physicians who die every year by suicide. In the end, Lorna only had one true risk factor, and that was being a physician. I started work on this submission several weeks ago, but with Laura's help, we finalized the application last week. The review itself will take 2 to 3 weeks, but I'll keep you updated once we receive a final determination on that. And for the remaining updates, I'll stratify those by department. So in terms of personnel in the licensing department, we have a full-time licensing rep or PSR3. We just finished a recruitment for. We extended an offer yesterday. We're just waiting to hear back from the candidate on that. We have a limited duration or temp office specialist. We extended an offer there, which was accepted, and that individual will start within the next week or two. The compliance department, I believe at the June meeting, I mentioned that I wanted to have some concrete steps or at least a plan in place for the compliance officer position we have vacant. And staff member Efremoff has drafted a timeline for the recruitment, which may begin as soon as the next 2 weeks. There are a couple final details we need to work out before the posting, but I think we're incredibly close to initiating that first step. Keep you apprised of any developments there. And of course, our strategic initiatives manager, Laura Shinoiki, started on 7/20/2026 and has hit the ground running. And not only did she play a critical role in helping revise the board's affirmative action plan and the narrative for the AY29 budget, she's also helped me get a few things across the finish line I've been working on behind the scenes for months. I'm incredibly excited about the progress we've already made and can't wait to see what we do over the next months. Speaking of accomplishments, I'll turn it over to Laura for a brief update on one of our recent projects.
Good afternoon, staff member Shinoiki. I'm excited to share that we have successfully submitted our affirmative action plan for review, as Gary stated. Throughout this process, we thoughtfully designed our diversity, equity, inclusion, and belonging targets to ensure every goal is achievable and closely aligned with our core objectives. The 3 goals for the next biennium are 1, increase diversity in recruitment, 2, deepen staff engagement by offering biannual training sessions and educational materials, and 3, utilize qualitative employee feedback to continuously improve culture, belonging, and retention. To bring this plan to life, we're actively using standardized hiring practices to interrupt bias. We also launched a staff reading club featuring leadership development and DEIB focused books and podcasts. And to keep that momentum going forward, we've mapped out a series of future DEIB staff trainings. Thank you, and I'll now turn the floor back over to Executive Director Runyon.
Executive Director Runyon, I think maybe we just got the books in, so we'll be rolling the communications out to staff probably next week for that. Thanks for the update, Laura. I'll wrap up here with a few updates in terms of our operations. I worked with Licensing Director Hennigan to considerably streamline and unify renewal language for several different license types. We created a tracking system for agency-specific and enterprise-wide policies and procedures. We started work on the strategic plan overhaul, which will be here before you know it. And the strategic plan meeting, I think, is early November. And so we've already started work on that. And we've also begun shifting focus to the software modernization project, which will be our highest priority item now that the biennial budget has been submitted. In terms of communications, in June, I mentioned that OHA brought to my attention that there may be some opportunities for pharmacists to play a role in increasing access to MMR vaccinations, specifically for the purposes of post-exposure prophylaxis. There are a couple roadblocks we had to work through there, but I believe we found some viable solutions. So I'll draft the public communication once I receive final direction. And as you've probably already noticed, I sent out a couple communications to licensees about the status of our respiratory vaccine protocols. And typically, we'd send those out with a general signature. However, I felt it was important to let licensees know that this is coming from me and that I stood behind what we were saying and that I was working diligently behind the scenes to find a solution. So hopefully that made an impact and cut down on some of the inquiries we were getting, but also by way of increasing the confidence of the communications put out. In terms of presentations, the Oregon Wellness Program Directors Meeting is coming up September 9th, and I was asked by Eden Banter, one of the individuals you met from the wellness program today, to introduce myself and the board of pharmacy as a potential partner at their upcoming directors meeting. I'll make an appearance at OSU to give our traditional P1 informational on September 28th. On September 29th, I'll present at OHA's quarterly pharmacy partners meeting, which is a remote meeting. We'll present at OSPA's annual seminar at the Oregon Zoo on October 10th. We'll host Pacific University exchange students in late October, and I'm working with Marquetta to determine when we can make another appearance on campus there with them. And in terms of upcoming travel, we have the NBP District 6, 7, and 8 meeting in Spokane, Washington, scheduled for October 18th through the 20th. And the very last thing, it's a feel-good update. We have our break room furniture that should arrive, here in a couple of weeks. So excited to see what that looks like in the space and really start using that to encourage all of us to take breaks and really just find that balance between work and self-care and as much as we can and have the ability to while on site. And with that, that concludes the financial plan and board and PFAC strategic plan and everything in between update. President Kirkbride, I'll turn back over to you.
Thank you, Executive Director Runyon. At this time, we will move on to our consent agenda. Is there any board discussion on the consent agenda? For myself, Board Member Kirkbride, no. Vice President Kroger? No. Member Chin? No. Member Hall? No. Member Joyce?
No.
Member Smith? Member Maslow? Okay. Is there a motion to move to approve the consent agenda as proposed?
Board Member Joyce.
Second, Board Member Smith.
Or even asked, I love it. Thank you. Board President Kirkbride, yes. Board Vice President Kroger?
Yes.
Board Member Chin?
Yes.
Board Member Hall?
Yes.
Board Member Joyce?
Yes.
Board Member Maslow?
Yes.
Board Member Smith?
Yes.
Different order. Motion passes unanimously. At this time, this is our time in the meeting for public comment. Nobody has signed up for public comment. So we do not have any public comment today. Do I need to read this, Rachel?
No, step number, nope.
Okay. Since there is none, that's nice. So next up, we will have matters to be discussed by the board where Each board member can take time to provide comments, ideas, or policy discussion items for future board meetings. And I'm gonna switch it up and I'm gonna go last. So we'll start with Board President or Vice President Kroger.
Member Kroger, nothing to discuss. Thank you.
Board Member Chin.
Board Member Chin, that we have a lot of money in the budget, but wasn't some of the budget to update our computer systems, and where are we at that?
Executive Director Runyon, that's what I was referring to when I was talking about the software modernization project, yeah. So that will be highest priority in terms of our projects now that the budget's been submitted.
Awesome, thank you.
For Hall.
Well, that was my same question. I'm sorry I missed that, but nothing else.
Heard you, Gary.
Someone is a friend.
Remember Joy.
Board Member Joyce, yeah, what I didn't hear was, or maybe I missed it, is there a replacement for the clinical advisor role, or is that gonna be Natalie Gustafson on a part-time basis, or did the old Jen Davis job?
Consultant. Services consultant.
Executive Director Runyon, that's the old pharmacist consultant position. That's what I was referring to when I mentioned compliance officer, because they're all coded as the same position, healthcare investigator advisor.
Yeah, I heard you say compliance officer, so I was a little confused. No, other than that, and thank you for the PIB presentation and for the action plan. That was good. Thank you. Thanks.
Remember Maslow.
Board Member Maz, there's nothing to discuss.
Member Smith.
Board Member Smith, none to discuss this time. Thank you.
I will wrap it up. And I've said this before, but I just think it's becoming ever more apparent that we really do need a legislative fix for pharmacists prescribing authority for vaccines, as this continues to take up a lot of time and effort by staff and our board. And so just encouraging that research and process to continue to look for a pathway, how we can simplify our statutes that relate to that, so we can make it easier here in Oregon to get these things done. So thank you. Now, Executive Director Runyon, any matters to be discussed by board staff?
Executive Director Runyon, no matters to be discussed by board staff. Just again, thank you as always for such an enjoyable and productive meeting. So thanks for your contributions.
Wonderful. So at this point, we have reached the end of our agenda.
In order.
Oh, yes.
Are we, are you going to the Spokane?
Yes, I plan on attending the NABP in Spokane.
We don't need to, vote on that or whatever, or approve it, so it's.
Not at this time, unless we need an alternate for some reason, and then we can. But that probably won't happen before our next board meeting. I didn't look at the dates closely. Oh yeah, we'll meet before then. I am slated to go and have it on my calendar. Thank you, Board Member Joyce. So is there a motion to move to?
Oh, I'm sorry, Staff Member Melvin, can you read the portion about the note taking? Those are for records. Thank you.
If you took electronic notes outside of OneDrive, please email your notes to rachel.melvin@bop.oregon.gov. Okay. Is there a motion to move to adjourn the meeting at 2:35 p.m.?
Board Member Joyce.
And Board Member Jim.
Board President Kirkbride, yes. Board Vice President Kroger?
Yes.
Board Member Chin?
Yes.
Board Member Hall?
Yes.
Board Member Joyce?
Yes.
Board Member Maslow?
Yes.
Board Member Smith?
Yes.
Motion passes unanimously. We are adjourned. Thank you very much.
Thank you. Great first meeting.
Thank you.
Visiting for Craig.